Thank you very much, Vipio. All right, so good morning, everyone. This morning we'll be discussing panic disorder. So I have already been introduced. I work at Kolebu Teaching Hospital, the psychiatry department. Thank you. So screen, I don't see my screen moving though.
Yes.
Okay,
Okay, it's moving
okay.
now.
So this is our outline. We'll look at the introduction, what panic disorder is, look at epidemiology, the possible causative factors, which is etiological factors. We look at risk factors, we look at features, which are signs and symptoms of panic disorder, and see how panic disorder is managed and conclude. So by way of introduction, panic attacks feature predominantly within the anxiety disorders. It's part of the anxiety disorders. All anxiety disorders may have some component of panic attacks, be it generalized anxiety disorder, panic disorder, post-traumatic stress disorder, and so on. And is a particular type of fear response. Fear is the emotional response to real or perceived threats. Now, anxiety disorders, of which panic disorders are part, are highly prevalent in the general population, and it causes much morbidity. It can cripple people such that they are not able to work, they are not able to continue their academic aspirations. So, they share features of excessive fear and anxiety and related behavioral disturbances. We all might have experienced some anxiety symptoms here and there. Perhaps we suffer from some particular phobia, such as women and cockroaches. I have not seen a single woman who doesn't startle when she sees a cockroach, including myself. And then we may have some little obsessive traits, making sure that things are in order. These are all components of some panic attacks. These make us panic. Like if you have an obsessive trait and things don't go that way, you tend to panic a bit. But we say it's a disorder when it has clinical significance, in that they are severe enough to cause significant distress and substantially interfere with your day-to-day life or activities. So before we see what panic disorder is, we have to know what a panic attack is. So a panic attack in itself may not be a challenge, because every now and then people may have panic attacks. Anybody can experience a panic attack. For instance, you're preparing for an exams and you get to the exam and what you studied for doesn't show up, then you tend to panic a little bit, or the fear of unknown, you are going to get married, some significant events happening in your life, and you start to have some panic attacks. It's brief, but it's not a problem. It's not too much of a problem. So panic attack is a period of intense fear characterized by a constellation of symptoms, which we'll delve into in the subsequent slides, that develop rapidly and reach a peak of intensity in about 10 minutes. Generally does not last longer than 20 to 30 minutes. It's rarely over 1 hour. So when you have it over this, more than when it exceeds an hour, then it's not likely to be a panic attack. Okay, so the attacks can either be spontaneous or situational. The situational ones occur where you may have had, an individual may have had attacks previously. And the attacks too may occur during sleep, which are considered as nocturnal panic attacks. And then in some rare situations, you may have physiological symptoms, such as palpitations, sweating, tremors, and all that. But there will be no psychological components. Okay, there's no fearful trigger. So what is a panic disorder? The disorder is recurrent panic attacks. Recurrent panic attacks, which are not due to substance misuse, not due to any medical conditions such as thyrotoxicosis or even behavioral seizures or any other psychiatric disorder. So we make a diagnosis of panic disorder when we have ruled out all these things. We make sure that this is not as a result of a substance misuse. This person is not in withdrawal from any illicit substances, either alcohol or cannabis or opioids and so on. It's not as a result of a medical condition. It's not as a result of a heart condition or even epilepsy, or it's not as a result of any other psychiatric disorder. Okay. So the frequency of occurrence may vary from attacks a day to only a few a year. Sorry. It's usually a persistent worry about having another attack and consequences of the attack. And these lead to avoidance of places. Because if you are afraid that I'm going to the market and what happened in the past, I developed a panic attack when I entered the market and I saw lots of people, then you become even fearful. You anticipate that it will happen again, and this will prevent you from going out. So that is usually the trend, and it causes significant behavioral changes. What does the research finding show? Worldwide, the lifetime prevalence of a panic disorder is between 1.5 to 3.7%. Okay, and then panic attacks is 7 to 9%. So as I mentioned, people usually have panic attacks. It's all right when it is a one-off thing, but when it becomes recurrent several times in a day, leading to a significant change in your social occupational life, then we know that it is a disorder. Okay, we have rates higher in medical clinics. So these are Western research findings. There's no substantial local data, but at best we have cardiac clinics. So the rate is higher in the cardiac clinics. A lot of people go to the cardiac clinic and they want to have several tests, do a stress ECG, do a lot of checks, sometimes echo, and they will necessarily move from one specialist to the other to make sure that they do not have a heart condition. It may all be a panic disorder. So, what are the causes of panic disorder? What are the etiological causes? It is very difficult to find the exact cause of panic disorder, unlike a disease. Okay, for a disease, you can identify a pathogen, okay, that is responsible for it. But for a disorder, it is very difficult to pinpoint that this is why this person is having this. So in mental health, etiological factors, we look at what we call the biopsychosocial model. So for panic disorders, there are theories that have been proposed as the more likely cause of the disorder. So it also follows the biopsychosocial model in that we have the neuroscience theory, which is the biological model, and then the rest come under the psychosocial model. So the psychodynamic theorists, the humanist existential theorists, the behavioral theorists, the cognitive theories, and then the sociocultural theories. I would explain each of them. So the psychodynamic theories, they believe that panic disorder or any form of anxiety is as a result of repressed situations in our subconscious. And they want to break free into the consciousness and the behavior, your behavior. So in their bid to do that, then a defense mechanism pops up. And the panic disorder is a form of a defense mechanism for the individual. Okay, so they think that this behavior is as a result of things that you have suppressed in your subconscious that want to break free and come out to reality, to your behavior. So it causes some conflict, and then before you realize, you are panicking and you develop a disorder. The humanistic existential theories, they believe that panic disorder, the source of panic disorder is as a result of the discrepancies between the self-concept and the ideal self. So that they think that if you perceive yourself differently from the way you would like to be, or you feel incapable of meeting life's challenges, then you start to panic and develop panic disorder. So that's what the humanistic existential theorists believe. The behavioral theorists believe that panic disorder and even agoraphobia, like avoiding public or getting panicky in public and all that is a learned behavior. So they believe that panic disorder, has the component of avoidance, learning, and modeling. Now, modeling in the sense that you realize that maybe growing up, you have observed your mother gets panicky when she's about to go for an event. So you are conditioned and you start thinking that, well, you have to panic when you are stepping out. Or you've observed your father preparing for an interview and you are told that your father is going for an interview and you realize that your father has become a little bit jittery, anxious, panicky and all that. And then you also learn that this is how it's supposed to be. So your parents or whoever raised you may be modeling the panic disorder in you. So that's what the behavioralists believe in, that how does somebody, develop panic disorder? It might be that the person has been modeled to become fearful, okay? And then they also believe that avoidance response is also part of the negative reinforcement that comes with panic disorder. So you avoid situations because of the panic disorder, and it's like a vicious cycle, and it makes the panic disorder worse. Okay, so the behavioral theorists believe that it is modeling, and then there's an avoidance behavior. We are conditioned about panic, like panic attacks and all that. So then that you end up becoming like that. Okay, the cognitive theorists believe that panic disorder is as a result of cognitive distortions in the brain. And by cognitive distortions, you may be having some deep-seated, distortions like unusual thinking about situations. So, for instance, somebody who has developed a panic disorder may be having a lot of distorted thinking, such as maybe when they start experiencing some unusual bodily sensations, like they're having a headache, they can catastrophize. And catastrophe is a distorted thinking. So they'll think that I'm having a headache, I'm going to have a stroke and pass out. Okay. And that is the distorted cognition. Okay. And this is what happens, and people develop panic disorder. So that's the cognitive theorist approach. So for instance, I had a client who had severe panic disorder. She was a banker, and well, she had diabetes and she had experienced hypoglycemia before. So she started getting very worried with any symptoms that she saw. Even the weather is hot and she's sweating, then it means that she's about to develop hypoglycemia. She's going to collapse. So she ended up carrying the glucose test strips and, the testers around. It was so disturbing because when she's driving and she's feels a little bit restless, she has to stop and prick herself and check her sugars. Okay. Got to a time she stopped driving because of that. She got a driver, but she'll be in the back seat and still become very afraid and have panic attacks and all. So in the end, she stopped even going out. She had to stop work and all that. But fortunately for her, her employer gave her time to recover, and she was a high-ranking officer in the bank, so she was given a period to get help. So that is the cognitive distortion. So they tend to catastrophize, very little things, like your leg is shaking, so it means that I'm going to get paralyzed. And this is what generates the panic symptoms. So that's what the cognitive theories believe in, that is the root cause of panic disorder. The sociocultural theories believe that stressful changes occurring in the society are the causes of panic disorder in people. For instance, with the onset of the COVID-19 pandemic, a lot of people had panic attacks, panic disorder, especially for us health workers. Sometimes maybe you are leaving your home and you are thinking, would I be exposed? You hear death of people, and it may cause a lot of anxieties in you, and you may think that you may develop it and all that. So it could be very crippling. So all these social issues, stressful issues in the society, the social cultural theories believe that that is what causes panic disorder. So for instance, like relationship issues, divorce, childbirth issues, infertility, financial crisis, and all that. We recorded lots of cases of anxiety and depression, the onset of all the financial crisis that came from last year, people losing monies from their investors and all that. So the neuroscientists believe that panic disorder is caused by chemicals, and there's a genetic underpinning to it. So that if you have a relation who has had panic disorder or any form of an anxiety disorder, then you are more predisposed. So if you have a first degree relative who has had panic disorder in the past, you have a 50% chance of developing a panic disorder should in case you have a stressful trigger. So they have done studies to show that panic disorder rates were higher in monozygotic twins than in dizygotic twins. Okay. So they also believe, the neuroscientists also believe that the serotonergic model is the reason for that. So these are neurochemicals. Serotonin is messing up, is going up. Noradrenaline is going up. There's an autonomic overdrive that produces all these chemicals, and these chemicals cause the symptoms of panic disorder, like heart racing, sweating, trembling, difficulty breathing, feeling like you're going to pass out, headache, diarrhea, and all that. And they also believe that the chemical that is supposed to inhibit these excitatory neurochemicals, which is noradrenaline and serotonin, the chemical GABA, which is supposed to inhibit them, is very low. They record very low levels in individuals who have panic disorder. So they believe that there's a problem over there, with their neurochemicals. The neurochemical imbalances are the result of the panic disorder. Great. So what are the risk factors? Women are 2 to 3 times more likely to be affected than men, okay? And the age of onset has a bimodal distribution, with the highest peak inset between 15 to 24 years. And I think it's understandable because around that time, there's a lot of identity crisis, trying to be accepted for your formative years. You battle with yourself. Okay, you need to find yourself around that age. Okay, so, and a lot of people, have social anxiety. Some of the guys were trying to, find partners around that age. So then sometimes the fear of being bounced neglected, all that can result in panic disorder. And the second peak is between 45 to 54 years. I believe around that age, a lot of people have midlife crisis. So then we record a lot of cases of panic disorders around that age. And it's rare after age 65, which is about 0.1%. Also, other risk factors include being widowed, divorced, separated, living in a city. Well, living in a city has become a risk factor. And I'm sure we all agree or we all know why it is so. Limited education, early parental loss, physical or sexual abuse. As a matter of fact, physical or sexual abuse is like the trigger to most mental health conditions. Like most of the time people come and we take the history, and if you find an element of physical or sexual abuse, you now understand that this can can be as a result of that, because the trauma and all that may have been concealed in the past, and the individual now growing up, maybe now getting into a relationship, getting into marriage, they start having all that fear again, okay, about the past experiences. So this is the Diagnostic Statistical Manual for Panic Disorder. I realize that it looks a bit busy, but I think I have explained in the previous slides already that panic disorder, to diagnose panic disorder, you should have recurrent unexpected panic attacks. And they have explained a panic attack as an abrupt surge of intense fear or intense discomfort that reaches a peak within minutes, and during which time four or more of the following symptoms. Okay, sorry, sorry. So you should have any four of these: palpitations, pounding heart or accelerated heart rate, sweating, trembling or shaking, sensation of shortness of breath or smothering, feelings of choking, chest pain or discomfort, nausea, abdominal distress, feeling dizzy, lightheaded, chills, heat sensation, paresthesia, numbness or tingling sensation, feeling of unreality, depersonalization, feeling that you are detached from yourself, okay, out of body experience, fear of losing control or even going crazy, fear of dying. So you should have four of any of these symptoms, okay, to qualify for that. And it should be going on for at least a month, okay? And it should not be due to any medical condition or substance use disorder. So this diagram shows the symptoms of a panic attack, and it shows the physical effects, like from head to toe, from the central nervous system. You're feeling dizzy, decreased self-drive is even there, irritability, sweating, chest pain, increased muscle tension, rapid breathing, palpitations. Your blood pressure can go up. You may think that you have hypertension. You may have some loose stools, nausea, diarrhea, and all that. So how do we manage panic disorder? So as I mentioned, because we believe that the etiological cause is a biopsychosocial model, we have to look at it in its entirety. Like, you don't just focus on one of the theories and run with it. So we look at the biopsychosocial approach in management. So when you see a psychiatrist or a psychologist, you will be examined, your history will be taken into detail, and will take into account all the proposed theories that may cause this, what is going on socially in the person's life. Are there any psychological traumas in the past? Are there any risk factors in the family, that is the biological? Okay, so we take a detailed history and examine you, and then we go on to make a diagnosis and investigate. And the investigation is also using the biopsychosocial approach. We will look at biological investigations to rule out any organic cause. That is this as a result of indeed a cardiac problem? Is this epilepsy? I have had a couple of clients presenting to my consulting room with panic disorder, and I suspected that it was epilepsy, and I had them do an EEG, and it came out positive. Two of them were doubtful, so they decided to go for a second opinion, and so had second testing for EEG and came out abnormal. So they returned to me and told me that they can't believe that they are having epilepsy at their ages. These were both in their 40s, but it presented like panic attacks. They have to stop driving because they start trembling and all that, and then it stops, and then they go on, and then it happens. So it was like really disturbing, and they were referred to see me, and I suspected that it could be epilepsy, and lo and behold. So we do all these things to rule out before we stick out our necks to say that this is panic disorder. We should have gone to town about the biological, investigations. Okay. We may even want to do a scan of your brain to check. Now, we can do thyroid function test too, because that can also present as panic disorder. Psychological investigation will mean doing psychometric tools. These are tools that are used to confirm panic disorder. We do not really need them to make a diagnosis, but it's just to confirm and also to monitor the outcome when we start medications. Sorry, social investigations will require us looking into your social triggers to find out whether there's any intervention around that, your work. So for instance, the banker that I had, I was able to determine that, okay, this is where she works. So a letter to the institution so that they know how long she's going to be on medications. And then they are also able to support their employees. Okay. So in the same way that investigation is a biopsychosocial approach, treatment is also biopsychosocial. So for biological management or treatment, we give SSRIs, which is selective serotonin reuptake inhibitors, such as sertraline, such as citalopram, escitalopram. In some cases, people can give fluoxetine, but it's usually not the first line. Okay. And then there are other medications, newer medications, SNRIs like mirtazapine. And then the age-old amitriptyline can also be given. Okay. So that is the biological, and you may be given some short courses of a benzodiazepine, such as lorazepam or diazepam, to help you to relax and sleep. Then we get to the psychological management, which will require therapy sessions. So if we employ the cognitive theorists and the behavioralist theorists, then we do what we call cognitive behavioral, we do cognitive behavioral therapy. And in that, the therapist will explore all your cognitive distortions and help you to reverse it and also develop suitable behaviors when these cognitive distortions appear. Then you are also taught to relax. So the relaxation therapy, progressive muscle relaxation, anytime you sense that you are about to have a panic attack, what to do, deep breathing exercises, squeezing your palms together, just relaxing your muscles. The individual is taught to do all these things several times to be able to be in control of the situation. And social management will involve a lot of things, multidisciplinary. Sometimes occupational therapists has to come in, especially for people who have had to be dismissed from work. So after treatment, the person has to be rehabilitated, integrated back into work. So they work with you to find out what you can do best. If it is issues about housing, then that one overseas, they'll find you a place and all that. But unfortunately, we don't have that here. But at least we have social welfare to cater for very needy people who may be having mental health challenges. All right. So on that note, I come to the end of my presentation. Conclusion, we should know that panic disorder is very common. It is not a condition of the West. Everybody can get it, and it's no respecter of persons. We should know that comorbidities are frequent. You may have panic disorder and have comorbid generalized anxiety disorders or post-traumatic stress disorder. You can even have depression as well. And the good news is that the medications used in the management of panic disorder are the same as what's used in managing depression. So we can kill two birds with a stone. Substance misuse disorders are also comorbidly related because individuals may, in attempt to actually manage their symptoms, they will resort to maybe drinking excessively or using illicit substances like cannabis, opioids, and so on. Panic disorder may often present with physical symptoms. So when you go to a general practitioner and you report with physical symptoms and they believe that it may be due to panic disorder and refer you to a psychiatrist, don't get bothered because the physical symptoms are the manifestation of the panic disorder. So management is a combined approach always, pharmacological and psychological. Cannot manage panic disorder with psychological management only. There's the need to chip in some pharmacological measures, given that the theories run across biopsychosocial. We cannot say that there's only the psychological underpinning, so then focus only on psychological management. These are my references. Thank you.
Thank you so much, Doctor. So now we'll take questions for Doctor. If you have any question that came up for you while Doctor was presenting, you can type them in the general chat or you can type them directly to the Silent Scream account. If you want to ask your question directly as well, you can also raise your hand and unmute and then ask your question. I see somebody called Raphael as somewhere unmuted. I don't know if you want to speak or say mistake.
Yes, I want to speak.
Oh, okay. Please go ahead.
Thank you very much, Doc. My name is Raphael. I am on the sertraline and clonazepam the past 12 months or so. I started, the doctor started with sertraline, I think 100 mg, and clonazepam started with, I think, 1 mg. Now it has reduced to, clonazepam is 0.5 now. It was cutting the product down, and selling is also now 25 mg. It has taken about 1 year now. I think about 1 year, 2 months. I want to find out if I have not stayed on these products for too long. Yeah.
Okay.
That's my question. Yeah.
Okay. Thank you very much for being very bold very confident and coming out with your diagnosis and all that. It's very great. I mean, this is how it should be, you know. So you being managed for panic disorder,
Yeah.
and currently you're on sertraline,
Yes.
and you got to, if I got you right, you got to a maximum dose of what, 100
100
or 150? 100.
and
Hello?
yeah, 100 for sertraline.
Very good. And now
Yeah.
your doctor has tapered down to 25, right?
25. Yes,
Yeah,
25.
so you are on a journey. I believe your doctor is looking to taper down and take you off, because usually we manage individual for at least a year.
Yes.
It's not cut in stone that exactly 1 year you should discontinue medications.
Okay.
So you're on a journey, and I think you've done very well. Means that your symptoms are very controlled
Yeah,
at even
minimize.
the 25. Yes. So your doctor is still observing you to see whether you would be okay,
Okay.
should in case he or she takes you off the 25, which is a minimum therapeutic dose. So you haven't been on it for too long. It's a process. So there are cases when individuals strongly believe that they are okay and they want to be off. So we give them the benefit of a doubt, but we inform them of the consequences of going off prematurely. And then you do a test run, and within a few weeks, if the symptoms arise again, if there is a relapse, then it means that you need to go back. So rather than break the therapy, rather than break, the duration, just cooperate and then go along till when both parties are convinced that you have really recovered, and then we can confidently take you off. Okay?
Okay.
So you have not been on it for too long. It's okay. I mean, the minimum is usually 1 year. But some individuals go beyond that a little bit because there are individual differences.
Okay.
Okay. All right. Thank you. Thank you.
Right. Maybe I will take your number and call you. Maybe talk to you later.
All right. That is fine.
Yeah. Currently, I'm in Canada. I will go back to Ghana maybe in 3 weeks' time.
Okay. So
Yeah.
you are being managed by a psychiatrist in Canada.
In Ghana.
In Ghana.
Yes.
Okay.
Yeah.
Okay. But you'll be going to Canada.
I'll be going back to Ghana maybe in 3 weeks.
Okay.
So when
okay.
I come back to Ghana, then I will get in touch.
No problem. You're always welcome.
Okay.
Okay. Bye.
Thanks.
You're welcome. Bye.
I see somebody called Aisha Gonda with their hand up. Please, you can speak.
All right, thank you. Good morning. I first of all want to say thank you for this opportunity, and it has been very insightful. But I just would want to also add that as someone on a graduate degree, and I mean a PhD, I think the the difficulties or the challenges that come with working and family, as well as pursuing such a degree. Hello, can you hear me?
Yes, please. Kindly go
Uh-huh.
on.
Yes. So I think there there needs to be some conversation about how the challenges that it comes with affects mental health, especially of combining all these with our current situation. So that's just what I wanted to add. Thank you.
Thank you very much. So it means that you are part of the social cultural theorist. It is good. All right.
Yes,
Thank
please.
you.
Yeah. Hello, Doc.
Yeah, hello.
Ralph. Yeah, Ralph again. I think my sister mentioned my situation, and I'm grateful to him. Sorry to her, and I think it is very important that maybe you help in this direction. I think mine started when I was on the verge of completing my PhD. And that was when the stress of work and then the stress of the program pushed me to. So it got worse. Immediately I completed the program. So that was when I started, experiencing um, the episodes. So I believe that we could go into the detail, these stresses and how we can minimize them. Seriously, she has hit right on the nail in my case. Yeah. Thank you.
All right. Thank you very much.
I see a few people have their hands up. I'm not sure if you want to speak or Doctor, please, there's a question in the chat. Someone is asking about parents. The person said, for parents who have anxiety, how do you know if you are being paranoid, overly paranoid, or if you are having the normal level of parental concern?
Yeah, hello. So I mentioned that every now and then we all may have some panic attacks. I mean, the fear of the unknown, okay, and all that, and the stresses. But it becomes a disorder when it is recurrent and it is distressing and it is significant enough to affect your social occupational functions. So every now and then, little worry about the future, it's okay. I mean, it's part, I mean, little anxiety, little anxieties are part of day-to-day life. But when it's a disorder, that is when it becomes a challenge and we have to intervene. Okay. So I don't know whether I've answered your question, but that is the little bits I can, explain. Thank you.
Thank you. I think there's one last question here. I'm not sure if anybody wants to put any other question in the chat, but I think this is the only other question we have for now. The person said, in the case where it's a specific person or place that triggers the anxiety, but cannot be avoided, how do you distance yourself? I don't know if the question is clear.
Yeah. So avoidance is not a positive. It's not a positive response. It rather perpetuates the panic symptoms more. So, individuals who use avoidance have to be worked on. The therapist will take you through how to gradually master the confidence to go through. So, we have something we call systematic desensitization. So, gradually you'll be exposed to the insult and then you gradually master. So for instance, yesterday, for instance, I had a client in my consulting room who had developed post-traumatic stress disorder because he was involved in an RTA. He was the driver just a few minutes before he got home in the night. He ran into a pole on the highway. So, and his car crashed, and this was a company car. So he was so concerned. For some days he was homebound. Well, he wasn't severely injured. He just had some little swellings and we did everything, medical screen. He was fine, no fractures. Okay, he didn't lose consciousness and all that, but he lost the car. I mean, the car got destroyed. Now, mentions that this is the only route to his house. He can't pass anywhere else. But in the beginning, he was very fearful because anytime he got there, although he wasn't the driver, he was a passenger, he would tell the driver to slow down and all that. So, but gradually, he himself, well, he got out of it, he mastered the confidence, and he drove to my consulting room, and that was his first visit. And he said that if he's been able to drive, and that is the only route to his house, be able to drive and come, and he'll be able to drive and go back, then he believes that he would get out of this. So avoidance is not a good response, it's a negative response. So when you're having it, it perpetuates the panic disorder. So we need to get you help to psych you up, but it's gradual. It will be associated with some anxieties if you have to take that trip, again and again. But with time, you get over it. Okay. Thank you.
Thank you. I saw two people unmuted. I don't know if it was a mistake or they wanted to ask questions, but we'll give you about 2 minutes. If not, then we'll start to wrap up. I see two people unmuted. Please, you want to speak? Okay, I think it's a mistake. Okay, I think there are no further questions for now. So we will wrap up, and then we'll also make sure to provide doctor's details so that if any question comes to you later, or you need a consultation, then you can reach out to her and then arrange something. So for now, thank you everyone so much for joining us this morning. Or if you're in a different time zone, maybe it's no morning, but thank you for giving us your 1 hour on this Saturday. We'll reach out again in the future for future events. So do also look out for those and then join us on those. The event was recorded, so we'll post the recording on our YouTube. The link will be made available. So if you want to revisit it or you want to share with someone that you think will need it, you can visit the link and then watch the recording again. Once again, please remember, you can visit our website, silentscreamfoundation.org. All the work we do over there, all the work we do is over there, and you can find out how you can volunteer and also contribute to this cause. You can share our Facebook and LinkedIn pages as well. We also put information there about future events. So if you want to join us next month, we'll have those information on our social media and on the website as well. Thank you once again. Thank you, Dr. Sheila. And we hope to see you all soon.
Thank you. Bye for now.
Bye. Thank you.
Thank you. Bye. God bless you all.